Definitely we are going to just brush up the things that are there in INI-CET. I welcome all of you on behalf of MediStudy Go, who have given a good platform for us also to interact with you guys who are, new bees and who are trying to get into INI-CET or get into NEET. These questions in INI-CET are also going to help you in NEET because they can be repetitive questions which can be asked from the same question bank as INI-CET questions come into. So let me introduce myself. I'm myself Dr. Omkar Balsaraf. I'm an associate professor in Department of Conservative Dentistry and Endodontics. I have also worked with Palak with the textbook on conservative dentistry and endodontics as a subject matter expert with MediStudy Go. I'm also editor of chief and editorial board member of a couple of journals. So welcome you all on behalf of MediStudy Go for this amazing and exciting lecture on INI-CET question revision. So I want this lecture to be interactive. So what we are going to do is I am going to flash a question. You guys will be answering it in the chat box. So I'll be keeping the track on the chat box. So let's see how many of you get the answers right. Okay. So this is the exciting book that we have already published through MediStudy Go, and it's getting a good response. Wherein we have targeted both the audiences in undergrad as well as the people who are preparing for NEET, wherein the NEET questions are being highlighted, as you can see in these patterns, wherein we have also highlighted the NEET questions which generally are asked for NEET exams, and also highlighted the important things which are important MCQ wise, or you can say it can be important like for your short answer questions or Viva point of view. So we directly start with the session. If you can just observe the screen, I have also mentioned the year of the question here. This is being asked in INI MDS CET May to 2024. So this is basically going to be a revision of all the conservative and endodontics questions that have been asked so far into INI CET. Okay, so according to ICCMS classification, initial caries stage is. So we have all the four options below. Firstly, when you're answering such kind of questions, you should be aware of what ICCMS classification means. So any right answers, if you want, you can put it in the chat box, please. Any guesses? Yes, I'm getting a few A's. So I got an A from Moni, Radhika, and Shruti. So they are talking about first visual change in seen in enamel only after air drying. Then you have distinct cavity with visible dentine. The third option being underlying dark shadow for dentine without localized enamel breakdowns. And also you have localized enamel breakdowns with no visible dentine. So you should be very aware of what ICCMS classification means, because there are many questions that are being asked every year on this particular topic. So generally they ask questions on ICCMS classification. Okay. So yes, I'm getting a couple of A's also again. So I'll just move to the next slide. That is the correct answer. You can see the correct answer is being highlighted in red. So that is how we are going to go ahead with the next questions as well. So the first visual change is seen in enamel only after air drying. So this is the answer for this particular question. We'll just come to what ICCMS caries management classification means. Okay, so it is International Caries Classification and Management System, that stands for ICCMS. Okay, and this pathway is a very complex pathway. They have given a very complex classification here, wherein there are various aspects of it. First being staging of the caries process, second being caries risk classification, the third is the decision metrics, fourth is being comprehensive patient management plans, and fifth being the outcome. If you just see this article wherein they have published this particular classification, you can see a complex type of a diagram wherein you have caries staging, then you have assessment of patient status, then you have synthesis and diagnosis, comprehensive patient care, and then the management part. So this is a complex thing that is being involved. As you can see in the first part, you have caries staging. So particularly caries staging, the question that we are facing is basically on this caries staging part, wherein there are various levels of caries that are there. Then you have caries risk and likelihood metrics, which is being determined by caries staging and assessment of the patient's risk, basically. Now, if you can just see in this particular aspect, you have uh, low, moderate, high. Okay, this is particularly about sound prevent sound lesions, or sound, or how to prevent the new lesions. That is basically risk management. Then you have inactive caries lesions and also active caries lesions, wherein active caries lesions can be initial, moderate, and extensive caries. So again, they can be either non-operative treatment for lesions and tooth-preserving operative treatment of lesions. So this is basically a complex matrix that comprises of that ICCMS classification. You should be aware of this classification. Only then you can answer such kind of questions. And this is a very important classification, because almost every year you can get one question from such kind of classifications. They'll give you one staging or one grading, or you can say one particular aspect, like initial active lesion, or a initial or a moderate active lesion, and they can ask you questions depending on that. Going to the next slide. Type 3 transportation of canal is repaired by. So we have either apexification, MTA plug, warm vertical compaction, and D is apical resection. So let's see what answers we are getting. You can type in your answer in the chat box, those who have joined recently. So we are answering the question based on type 3 transportation of canal that is being repaired by. So first is apexification, that is formation of a root by synthetic materials, MTA plug, also warm vertical compaction, and apical resection or surgery. Okay, some guesses coming up. Any other answers? It's okay if even if you're wrong, that is not a problem, but you will get to know why you're wrong. So you can just type in your answer, not a problem. No one is going to judge you for this. Okay. No other answers. Shall I go ahead? Okay. The answer is apical resection. Now, to understand what is a type 3 canal transportation, we need to know what are the types of transportation. It is being given in this particular article called as critical evaluation of root canal transportation by endodontic instruments. So basically, there are various factors that govern the impact and incidence of canal transportation. First being the root canal anatomy or the degree of curvature. There is a radius of curvature for any kind of root. Okay. Then second is the file design. What kind of file design are you using? Okay. What kind of taper does it have? What kind of what you can say? What are the helical angles, the pitch, the cutting angle? All these things will govern your impact of these instruments on the particular canal transportation. Also, what kind of alloy are you using? So NITI instruments are much more, you can say, less of cutting at the tip. So they have less of chances of canal transportation as compared to your stainless steel instruments. Definitely instrumentation techniques. What kind of force are you using? What kind of movement are you giving? So rotary instruments are going to have more kind of more impact on the canal transportation as compared to the reciprocating, because reciprocating will be going into a direction like clockwise and anti-clockwise subsequently. So there are various methods of finding the canal curvature. You can also get questions on these as well. Okay, so there are various methods of canal curvature. What you can say, locating what is the angle of canal curvature. So basically, one line is drawn from the orifice, okay, towards the root, and then you have one more line that is being drawn, and the angle in between them from the curvature basically, and the angle between them is recorded as an angle. So this is called a Schneider's method. There are various other methods as well. We'll be just coming to that as well. Okay. So if you can see, C pilot, C plus, reamer, headstrom have cutting tips, allowing a catheterization of narrow calcified canals. That is why NITI files, when you're using that, definitely they have no cutting tips. So they have non-cutting tips. So whatever guide path you have maintained, the NITI files are going to definitely follow that particular path. Okay. So as I told you, there are other methods also for finding canal curvature. So there are so many methods wherein you can get a question upon. So Schneider's method, Wien's method. So all these methods, there are so many methods. If you can just see here, so there are so many methods that are there in the literature. You can get any method on which they'll ask you what is the canal curvature. Almost every method will give you the same canal curvature here and there. Okay. So coming to canal transportation, there are three types of canal transportation. Type 1 being a minor movement of the position of the physiological foramen, also called as ledge. This is they are managed by try to create the right angle architecture. Okay, if you are seeing here, you are just trying to miss out the canal. You are forming a ledge here. Okay, so in type 2, you have moderate movement of the position of the physiological movement, that is also called as zipping or tearing. Okay, this requires a non-surgical application, and as Radhika said, MTA. I guess MTA. It is MTA is basically for type 2. If you see in type 3, there is severe movement of the position of the physiological foramen, also called as perforation. So this needs an immediate corrective surgery after obturation, that is also called as a periapical surgery. Okay. So your answer is type 3. So these are the three types of canal transportation. As we mentioned, this is the normal canal, as you can see in gray. In B, you can see there is minor amount of canal transportation, that is type 1. In type 2, you have moderate movement of the apical foramen. So this is the apical foramen. You have this as your prepared canal. So this is called as canal transportation, wherein your canal is getting transported from the apical foramen and you're making some other non-physiological access to that particular area, that is called as canal transportation. And this is the in the deep picture, you can see there is a lot amount of what you can say severe movement of apical foramen, and this needs a corrective surgery basically. Coming to the next question, best prognosis of perforation is in which region of the root? So you have furcation area, you have apical perforations, you have middle perforations, and also have cervical perforations. Now, these are the questions wherein you have basically they are being framed by people who are remembering these questions. So they might not be exact, but this is what the best out of the lot is. Okay. So I'm getting a couple of B's or C's. So just handling this question the other way around, the worst prognosis for perforation is A. It is going to be a furcal perforation because it is very difficult to manage. There is a lot of saliva coming inside, and it is very difficult to isolate this particular furcation area and repair this furcation area at the same time because there is a lot of bleeding, also salivation, also GCF that can be contaminating that particular area. So coming to this question, we are seeing the best prognosis. It is basically the answer is B. Okay, so it is apical perforation. Why apical perforation? Because easier isolation can be done. Distance from the gingival sulcus is more. Better healing environments. Okay, minimal. So sorry, minimal periodontal involvements, and also successful sealing can be done. You can have a good hermetic seal of that particular area with bioceramic sealers or say MTA or biodentine. Coming to the next question, single canal arises from a pulp chamber and during its course, it splits into two and ends in two canal at apex. This is vertices which type? So you will definitely get a question on vertices classification also, this being a tricky thing. So I'll just give you, after the answer, I'll give you the hint for it, how to remember about it. I'm getting a couple of responses. I'll just wait for everybody to finish. You might be wrong, not a problem, but you will remember being wrong here and you will remember the right answer as well. So I urge everybody to, at least type something so that it will be a memory for you. Whether it is a wrong answer, you will remember that why you were wrong. Okay, because I'm giving justifications in the coming slides. Getting a couple of A's, couple of D's. Just wait for a few responses more and then we'll go to the final answer. I hope I'm going at a good pace. I'm not being too fast. If I am being too fast, please let me know. I can slow down my pace. You can type it in the chat box if you have any doubts. We can take them during the session or after the session. Not a problem. Okay, so the answer is D. Yes, quite many have answered D. Quite many have answered A. So we'll just go to how easily you can remember this. If you can see, there are various classifications given by various authors, out of which vertices is the one which is being standardized and followed many of the times. And also questions arise definitely on vertices classification. They'll ask you any kind of classification. So I recommend you writing type 1 as 1 1, type 2 as 2 1. So subsequently, if you write down and remember it in that manner, it will be very useful for you. For type 5, you have 1 and 2. Since the question, you can just, we'll just go back to the slide on the question. The question being, single canal arises from pulp chamber and during its course splits into two and ends in two canals at apex. So it is one canal that goes and splits into two, okay, during its course and ends in two canals at the apex. So this is what this is which type. So we can just see type 5, wherein it goes as one, splits into two, and exits as two itself. So it is a type 5. Okay. Coming to the next question, you have root and conditioning material with MTA as root and filling material. The conditioning material is used is what? Basically, the question is, what is the root canal conditioning material used with MTA as a root canal, a root and filling material? So when you're using MTA as a root and filling material, what kind of conditioning agent will you prefer? So first is citric acid, second is phosphoric acid, third is EDTA, and fifth is acetic acid. Yes, I'm getting a couple of responses. I'm just waiting. Yeah. That's it. I'm getting few answers as option C, that is EDTA. Whenever you're remembering these materials, I'll suggest you please remember with their concentration. So EDTA is going to be used as 17% EDTA, phosphoric acid as 37% phosphoric acid, citric acid as 10% citric acid. Acetic acid can be used in variants depending on its use. Okay. So the right answer here is not EDTA, which responses I have got. EDTA is nothing but ethylene diamine tetraacetic acid. It's a smear layer removal agent. Here, when you're doing a root end filling material or you're doing a root conditioning for the MTA, which is to be used as a root and filling material, you do not need EDTA, neither you need phosphoric acid because we are not removing any kind of smear layer. Neither are you going to use phosphoric acid to make those tags in it. Okay. So what we require is citric acid. Okay. So the right answer is citric acid. You always require citric acid conditioning when you're doing a root and filling material like MTA. Okay. So we go to the next question. Now you'll have to read such kind of questions. There are lengthy questions like these. You can keep them as the last things to answer if you are in a fresh mood, or you can, if they are coming in the sequence, if they're coming initially, if you feel that too much of time is being wasted in this, you can keep them as handy and later you can answer them. They can be very easy. They might look tricky. Okay. So we'll just see this question. Which of the following is true? Now, please remember here you are supposed to follow what they are trying to ask. So here they are asking which of the following is true. So they're not asking false. They might ask here false, or the question can be framed which of the following is not true. Okay. So please remember and go through the question very, very carefully. So here the question is which of the following is true for current endodontic irrigation protocols. So first they are saying that 26 gauge needle is used. Second, they're saying use side vented needle or close end needle. Third, they're saying 1 to 3 mm from working length, and the flow rate should be 4 to 6 ml per minute. So the answer to this question, they're given options like A, it is 1, 2, and 3. B, it is 2, 3, and 4. C, it is just 3. And D, it is 1, 3, and 4. This is a very, very tricky question. Anybody would like to answer here? Yes, I'm getting a couple of responses here. Any more? I'll give you time because this is a long, long answer, long, long question first of all, which needs to be analyzed properly. You might get what you can say, a working sheet or a rough page to work on. So on that page, whenever you're answering in the NEET exam or in the INI-CET exam, you can just get hold of those which are not true and just cut them out so that you can answer the question properly here. Any answers, any more answers? I'm just waiting. Can analyze this question properly because there are so many things to be analyzed. First of all, is you should be very, very importantly focusing on which of the following is true. Okay, so what are the statements that are true is what you're supposed to follow. Current endodontic irrigation protocols. So they're talking about the newer irrigation protocols. We are not talking about the conventional or the old irrigation protocols. These are the new ones. Okay, so what are the recommendations that are given in the new protocols is what they're asking about. We're still waiting. I'm just waiting for you guys to analyze. Please take your time. Okay, we move to the answer now. So the answer is B, that is 2, 3, and 4 are right. So use side vented or closed end needles is right because what happens if you're using a side vented or a closed end needle, your irrigant doesn't directly go towards the periapical area, neither it goes beyond the apical foramen. Okay. There is also a piston effect that is being caused because of this closed end, because of this open-ended needles. That is why side vented or closed end needles are generally preferred when you're using endodontic irrigations in the root canal systems. Also, the third option that is 1 to 3 mm from the working length. Yes, your needle should be slightly away from the working length. You should not go till the working length to irrigate. Okay, so whatever irrigation is to be done, it should be done away from the apical foramen, slightly away, that is 1 to 3 mm away from the working length. Also, the flow rate should be 4 to 6 ml per minute. So it should be very steady and very, what you can say, passive irrigation that needs to be done. There are two types of irrigation. Again, please remember, one is active irrigation, one is a passive irrigation. In active irrigation, you have ultrasonics that can activate that particular irrigant. Okay. So these are called as active irrigations. You have passive irrigations wherein you are just irrigated. Okay. You can use your gutta percha also to activate that irrigant. Okay, so you can use master cones. There are various other instruments like endosonic instruments which can activate that particular irrigant. Okay, so also called as endo activators. Okay. So this can be referred here, wherein we have this review article wherein they have already given the expert consensus on irrigation and intracanal medication in root canal therapy, wherein they have given all the things that are there inside this particular answer that we are supposed to know. Okay, so this is the first thing being fill the pulp chamber and root canal with irrigants before the first step of root canal treatment. Always keeping the root canal system under irrigation immersion. You should always keep the root canal chamber filled with your irrigant. Frequent and extensive root canal irrigation should be performed during mechanical preparation with 2 ml of irrigant per canal between file replacements. Every file, whenever you're replacing every file, you should be having your irrigant inside. Okay, a total of 10 to 20 ml of irrigant is used for each canal during the whole treatment. Okay, so these are the basically the gist of it. Whatever the current scenario is, that is what they're trying to tell you. Also, they should be using a Luer lock threaded fitting. Okay, because when you're pushing it, the needle should not just go out with the pressure is what they're trying to tell you. Also, you can see here possibly at a 2 mm away from the working length is what they're trying to tell you. So 1 to 3 mm away from the working length is again one of your options that was there in the question. Again, coming to a big question, which of the following is true for selecting correct time of obturation? So what is the correct time of obturation? What I interpreted out of this question is basically it was not being framed properly because you can see many of the things not being in right this thing. But we'll just try and analyze this question. So the first statement being temporary restoration is intact. Second being negative bacterial culture obtained. Third is no exudate from canal. And fourth being patient is asymptomatic. So now out of all these four, we have to select A being only two, B being one and three, C being one, three, and four, and D being one, sorry, C being one, two, and four, and D being one, three, and four. Any guesses? Yes, couple of answers coming up. Any more responses? Yes. So the answer is D, wherein temporary restoration is intact, is what they are saying. No exudate from the canal, and patient is asymptomatic. So when do you decide whether the patient should go for a obturation? Is what they're trying to tell you. So this is basically particularly pertaining to symptoms, because if you're taking an X-ray for a case that is having an abscess when you're starting with, so it is going to have some periapical radiolucency, which is suggestive of an abscess or a periapical pathology. This doesn't recover with time so easily, because you'll be waiting for what, say, 3 to 4 weeks of time for 3 to 4 dressings of intracanal medicaments like calcium hydroxide. We'll wait for that tooth to be asymptomatic. So asymptomatic in the terms of pain, and secondly in the terms of swelling or exudate from the canal. So if there are weeping canals, so exudate from the canal is basically weeping canal, pus from the canals. So no exudate from the canal is what you'll be looking for. Temporary restoration is intact is what they're saying, and patient is asymptomatic. Asymptomatic is that the patient is having no pain at all. Negative bacterial culture obtained. This is very, very technique sensitive, and it is a thing that was done earlier. So it was also called as culture testing. Okay, in the canals, wherein you just swab the canal, and make the culture out of it, and just check whether any kind of bacterial growth is there in the culture or not. So this is called as negative bacterial culture. It is very time consuming, and it takes almost say 3 to 4 days to get a negative culture. And by then, if you have a breach in your coronal restoration, your canal can have again the presence of bacteria, which can be again a pseudo positive case here. So we generally don't rely on that. Coming to the next question, tissue dissolving property of sodium hypochlorite depends on, first is volume, second is concentration, third is pH, and fourth is temperature. So the answer A being 1, 2, and 3, B 2 and 4, C 1, 2, and 4, and D being 3 and 4. We'll just wait for the responses. Yes, any responses? Bit of a tricky question. We are now moving towards the image-based questions also. We'll be facing the image-based questions as well. Yes, any responses? Any more responses to come? We'll just wait for a few minutes. Yeah, I can see many mixed responses. So coming to the answer, it is B, that is 2 and 4, that is your concentration and the temperature. Now, as we know, sodium hypochlorite can be used in various concentrations from 0.5 to 5.25%. So we know that there are varying concentrations of sodium hypochlorite. Also, if the temperature of the sodium hypochlorite is increased, definitely it gives more tissue dissolving properties, what the studies have told us. pH can't be altered of sodium hypochlorite, also volume. Yes, but volume, how much volume are you going to irrigate? We have already seen that we need to go with 4 to 6 ml per minute. Okay, so to avoid any kind of sodium hypochlorite accidents, we have to use it limited and you have to use it very cautiously. Okay, so the right answer being concentration and temperature. There is a graph also for this, wherein what kind of concentration and what kind of temperature is there. Okay. Coming to the next question, tooth cracks associated with the reversible pulpitis. What should be the treatment? So first is identify cracks and fill with composite resins. Then you have bilateral splinting with endodontic treatment, and D being full coverage crown. We'll just wait for another few responses and then go back to the answer. Please read the question properly. The tooth cracks are associated with reversible pulpitis. If you know what reversible pulpitis means, is there is pain on stimulus. When you remove the stimulus, the pain goes away. So there are two types of treatments for reversible pulpitis here. If the patient is symptomatic and the patient is not symptomatic. If the patient is symptomatic, you go ahead with giving some painkillers to the patient and excavating the caries if they are the source of the particular stimulus. So you remove the caries, you give a soothing dressing like a zinc oxide eugenol dressing. You wait for 3 to 4 days for the pain to subside and then go ahead with a removal of the soothing dressing and giving a permanent restoration once the pain is gone. So this is one aspect of dealing with reversible pulpitis. Secondly, if the patient is asymptomatic and is having pain only on the stimulus that is there, okay, so you remove all the caries and give a permanent restoration. That is the treatment for reversible pulpitis. So identify cracks and fill with composite resin is the answer, because whatever cracks are there, you generally fill them up with the with the composite resins to avoid the reversible kind of pulpitis that is there around. Okay. Splinting with endodontic treatment is not required, because if you're splinting and also again giving endodontic treatment, it is of no use. Full coverage crown is only given in cases wherein you have fractures or wherein you are going for an endodontic treatment. Post endodontic treatment, you go for a full coverage restorations. Okay. Coming to the next question, pulp treatment in which restorative material is directly placed over the mechanical exposure during treatment to maintain pulp vitality and root formation. So pulp treatment in which restorative material is directly placed over the mechanical exposure during treatment to maintain pulp vitality and root formation. A being direct pulp capping, B being indirect pulp capping, C being Swex pulpotomy, and D being partial pulpotomy. Here we have to analyze all the options rightly. Okay. Now, just to tell you here, how they are trying to trick you is C and D are the same options, because Swex pulpotomy is also called as partial pulpotomy. Because if you see the procedure, Swex pulpotomy, you remove the coronal pulp, 2 to 3 mm of coronal pulp, okay, so that to maintain the radicular pulp intact. This is generally done in pediatric cases or young individuals, wherein you know that healing is going to be faster and you can have a good hemostasis or control of bleeding in that particular pulp chamber. So this is about Swex pulpotomy and partial pulpotomy. So both are out. Coming to DPC and IPC. DPC is direct pulp capping. IPC is indirect pulp capping. We have given a very fantastic chart in the textbook that is there on Conservative Dentistry and Endodontics in how to compare between DPC and IPC. Basically, when you are seeing about or going for indications about direct pulp capping, there should be a pinpoint exposure Okay, that should be mechanical. You can see the word that is being specifically given here, mechanical exposure during treatment. Okay, so there should be a mechanical exposure which is non-contaminated. A pinpoint exposure, not a huge exposure, will do. Okay, so a pinpoint exposure, mechanical exposure with non-contaminated. It is to be non-contaminated totally. Okay, it can be due to a process wherein you are going for a crown prep of a tooth, and you generally go ahead and you can say expose the pulp. So in these cases, you generally go for direct pulp capping, wherein you place the medicament or the particular endodontic material directly on the pulp. So this is called as direct pulp capping. So the name itself suggests direct pulp capping. You place it directly over the pulp. Whereas in indirect pulp capping, you scoop out the caries, you know that you're going to enter the pulp. Okay. And this is a very big caries exposure that is there. There's not an exposure of the pulp, but there's a huge caries there which you are trying to scoop out. And you know that after scooping this particular layer, I'm going to go directly inside the pulp. So you intentionally keep some amount of caries, superficial caries there, above which you place your medications. Okay, so the medications for direct pulp capping and indirect pulp capping being the same. They are the same medications that you generally use for direct pulp capping as well as indirect pulp capping. Okay, so coming to the answer, it is either A or B. Okay, so the answer is rightly guessed by you guys. It is A. Okay, it is direct pulp capping. Please stay focused on the question. As I told you, mechanical exposure is what needs to be highlighted in this particular thing. Okay, so mechanical exposure. Also, they are saying that it is directly placed over the mechanical exposure. So anything that is being placed directly over the mechanically exposed pulp is about direct pulp capping. Okay. So this is the Swex pulpotomy. As I told you, it is also called as partial pulpotomy. So this was a tricky question trying to fool us between C and D, because C and D are generally done in you can say pediatric cases, wherein only the coronal pulp is removed, the radicular pulp, the pulp in the roots is kept intact, over which you have a formocresol impregnated cotton pellet that is being placed, above which you place your cement, above which you have a stainless steel crown that is being placed over it. Okay. Yes, this is the most favorite questions of INI-CET people. They have a question on resorption. As I told you, there is a question on classification, either on ICCMS, or they can you'll have on some other classification of caries. Likewise, you'll have a question on resorption in your question paper. If you see previous year's question papers, I've gone myself gone through almost 5 to 6 years question papers. I've come across such kind of questions definitely asked in your INI-CET papers or NEET papers as well. So they have a particular question on this particular aspect as resorption. Okay. So patient gives history of trauma few years back, and now he has come to the OPD with this X-ray. This is, now you have to analyze the X-ray properly. Okay. When you have image-based questions like these, okay, my particular suggestion for you guys is when you are analyzing such kind of X-rays, there are two approaches that you take. You either scan the entire X-ray and then move on to the question, which will take you a lot of time because you are not sure what the examiner is trying to ask you. So the easier way of approaching such kind of question is read the question first, then go back to the X-ray, visualize that part, and then answer. Because there are n number of things that are there in the X-ray. You can't analyze each and everything in the given the amount of time that you have. So what is the area of interest of the examiner? What is the area of interest of the answer? You go directly to the question first, read the entire question text, then go back to the X-ray until unless it is highlighted. Suppose they highlight a part with a ring or suppose a different color and or an arrow suggesting that this is what the pathology is. Till then, don't go to the X-rays. What my suggestion is, okay, but it works for everybody in a different manner. So you can follow as you have been following till now. But to save time is what my suggestion would be. First, read the question, go back to the X-ray, see the X-ray, see the things that have been come across here, try to correlate the question and the X-ray, and then come back to the answers. Yes, coming to the question, the options being external inflammatory resorption, B being replacemental resorption, C being exterior internal resorption, and D being Hershey's type 4 resorption. So let's see, we'll just wait for a few minutes for people to answer because this is an interesting question. After a long time, we have got a image-based question. We'll just wait. Just trying to give you a highlight of this. Just understand the history. What is the history? It's trauma. How many years back? A few years back, the patient has come to the OPD with this X3. This is okay. You should be well versed with all types of resorption because they can ask you any kind of resorptions. Okay. So anything starts from the root canal, you can see if you see something that is started from the root canal, it is definitely a internal resorption, a type of internal resorption. Okay. We'll come to the answer of this also. Also, to give you an aspect of what is the treatment of such kind of things, if they give you such kind of an X-ray, here they have asked you what condition it is. In some cases, they can ask you what is the treatment of it. So any kind of resorption needs to be analyzed with CBCT to get to know what are the kind of perforations that have happened. Okay, whether it is a perforating resorption, whether it is only an external resorption, whether it is an internal resorption that is communicated to the external surfaces. So all these things need to be identified first. Secondly, you are supposed to make a access cavity preparation in that particular tooth. Okay. Then you place calcium hydroxide. Why calcium hydroxide is placed? Because to avoid any kind of further resorption of the tooth, okay, you go ahead with access cavity preparation. You place calcium hydroxide. Calcium hydroxide will give it an alkaline medium, okay, which will neutralize all these acidic phosphatase that has been created because of osteoblast. We need to neutralize all the acidic phosphatase by alkaline phosphatase that is being created because of your calcium hydroxide influx, right? So calcium hydroxide will act as a agent that will stop this kind of resorption. Okay. Once you are sure that this resorptive process has been arrested, okay, that takes almost 4 to 6 weeks. You never know when it has stopped. Okay. So you generally wait for 4 to 6 weeks. That is the time span for every kind of resorption that you need to handle. After that is being taken care of, once you know that the resorption process is arrested by your 4 to 6 subsequent dressings, after that you go ahead with obturation and perforation of any kind of the resorptions defect if there are any. Okay, so coming to the answer, it is external inflammatory resorption. Now you can see here external inflammatory resorption, you can just see such kind of eating up of appearance here. Okay, you can see in this X-ray as well. Okay, it is an eating up appearance that you can see. Okay, so this is an external because it is starting from the external surface. Inflammatory, why? Because there has been a trauma. So in resorption, basically your own cells are trying to eat the cells of the tooth, right? So in this particular case, it is external inflammatory resorption. So these are the various types of resorption that you can see. Okay, internal resorption and external resorption. Internal resorption, there is surface resorption, tunneling resorption, inflammatory and replacemental resorption. Also in external resorption, you have surface, cervical that is in the cervical region. Inflammatory, as we have seen, such kind of eating up of appearances. Replacemental resorption is very similar to inflammatory resorption. But in inflammatory resorption, as you can see, those areas of radiolucencies, you might not see in replacemental resorption because in replacemental resorption, so, some kind of osteoid tissue, like or bone-like tissue, is being deposited in this particular areas. I have given references to everything that I have been mentioning here. This is an international endodontic journal that has published such kind of an article, okay, in 2023, wherein there are various types of resorption that have taken under one roof, and they have explained very nicely about how this particular resorptions goes ahead, okay. And the last one is being transient apical breakdown. So your apical resorption, apical transient resorption, wherein the apical area gets eroded. Okay, so this is called as transient apical breakdown. Okay, so this is an article from your International Endodontic Journal, right? They have also given a very nice chart wherein they have shown all the predisposing factors along with odontoblast and macrophages, how this particular reaction takes place. That is RNKL, rankle that is there. Also TNF alpha, interleukin 1 to 17, what is their role, how the inflammation occurs. So very nice chart that is displaying everything related to your resorption. Okay. So basically, trauma and caries will create gram positive, gram negative spirochetes. They'll stimulate the Rankel system. Okay. So you have your TNF alpha and interleukin stimulated. They'll activate the recruitment of odontoblast. Okay. So they'll form odontoclast. Clasts are breaking down cells. Okay. And so on, the entire process goes on. Okay. So we are not going into the depths of it because it will be very theoretical. Okay. We are just focusing on the main things. Thickness of MTA barrier is the next question being thickness of MTA barrier is 1 to 3 mm, 5 to 7 mm, 3 to 5 mm, and depends on length of root. Okay, so this is again a tricky question. We'll just wait for the responses. I sincerely urge everybody to attempt it once, because if you attempt it and even if it goes wrong here in this session, it is not a problem. But you will remember why you have been wrong, and you will remember it for a longer period of time. Okay, so you'll remember the answer as well properly. Yes, we have a question here. They're saying that I have a doubt whether calcium hydroxide will cause resorption in some cases. Basically, it will not cause resorption, but the dentine will be softened because of it. Because calcium hydroxide can't be placed more than 4 to 6 weeks. It will cause a degeneration of the collagen fibers that is there inside the dentine. That is why you're not supposed to keep the calcium hydroxide for a longer period of span. So definitely it is not going to cause resorption. It is the basic material that can arrest resorption. That is the only material that can arrest resorption, because you have acidic phosphatase that is being created there, as I told, we just discussed, that the odontoclasts are being formed, that are the cells that eat up that area. Okay, so we need to arrest that part. So arresting that part can be always done by your alkaline phosphatase, which is because of your calcium hydroxide influx. As the calcium hydroxide, as we all know, that the pH being 12.5 and the area being acidic, we place the alkaline medium inside. Okay. Coming to thickness of MTA barrier. So we are getting the answers. Yes. Good. Now I can see people answering. Yes, many people are answering it right. So it is 3 to 5 mm. Good. The MTA thickness, the barrier of that MTA thickness is 3 to 5 mm. Okay, we'll just come to the conclusion. In many of the cases, MTA barrier is given. Where is MTA barrier given? Basically, in open apex cases. We have open apex cases in many young individuals where the apex is not being closed. Okay, we have blunderbuss canals. In those cases, to close the barrier, okay, it doesn't happen with a natural thing. Okay, so what we have to do is we have to place a MTA barrier. Okay, so what is the thickness of that MTA barrier? It is somewhere around 3 to 5 mm. So here in this particular article, okay, which is in Journal of Conservative Dentistry and Endodontics, you can see MTA placed in the apical region 4 to 5 mm of the canal to form an apical barrier. So such kind of barrier is being placed to avoid any kind of exclusion of the material of the obturating material outside the canal. Okay, so we are supposed to preserve such kind of areas wherein we have open apex. The apex is not being closed because of n number of reasons, trauma being one of them. Okay, so in those cases we generally go ahead with your closure of your apex with MTA barriers. So the thickness being 3 to 5 mm or 4 to 5 mm to be precise. So best anatomical parameter to predict root canal morphology of mesobuccal root of maxillary molar. So we have the options as depth of MB2 canal, inter-orifice distance between mesobuccal 1 and mesobuccal 2, third being width of mesobuccal root, and fourth being angulation of mesobuccal root. We just wait for a few answers to come in. Yeah, I'm getting a couple of right answers. Yes. Best anatomical parameter to predict root canal morphology of mesobuccal root. of maxillary molar. So maxillary molar, as we all know, there's an extra mesiobuccal root. They have been labeled as MB1 and MB2. Okay. So the answer here is inter-orifice distance between MB1 and MB2. Just remember this kind of a diagram that you will get to know. So this is the distance between MB1 and MB2. Okay, so this is an important anatomical parameter to determine or predict the root canal anatomy or morphology of mesobuccal root of maxillary molar. Okay, you can see this. This is called as inter-orifice distance between MB1 and MB2. So this is one orifice and this is the other orifice. This can be only visualized under microscope or loops. So if you have loops or you are working under a microscope, you'll definitely get to know where your MB1 and MB2 are located. So this is the distance between them. This is an important parameter that decides your prediction of the root canal anatomy of MB1, okay, or the MB root, okay, whether you are supposed to have an extra mesobuccal canal or not, okay. So this is being determined by this. These are the orifices: distobuccal, palatal. You can see the palatal orifice being the largest, okay, and they are being connected by something called as dentinal map. So they are being connected by a dentinal map. So if this map, you have one more orifice here, so you will have some darkened line there that is called as dentinal map. You can trace the dentinal map. It is not being there in all the cases. In calcified teeth, it is very difficult to locate the orifice depending on the dentinal map. Okay. So location of MB2, as you all know, you have something called as champagne bubble test. Okay, in that what you do is near the orifice you place sodium hypochlorite. So because of that effervescent action or the action which dissolves your organic tissues, you definitely go to negotiate MB2 properly. Okay, so this is definitely under magnification. You can have such kind of a fantastic image, or it is very difficult to locate MB2 in those cases, right? So under magnification, they have said that it is almost in 92 to 95% cases wherein you have MB2. So almost all the cases in maxillary molars will get MB2, right? In the first molar cases, but under magnification alone. 18-year-old male patient reports with yellowish discoloration of maxillary central incisors and gives history of trauma almost a decade ago. So 10 years down the line, he had some trauma. So now he has some yellowish discoloration of central incisors. Radiographic examination shows pulp obliteration. The ideal treatment is. We have an 18 years old male whose reports to the OPD with yellowish discoloration of maxillary central incisors. He also gives history of trauma almost 10 years back. Radiographic examination shows pulp obliterations. Ideal treatment is. So now when you're analyzing such kind of questions, okay, I'll say these are incomplete questions, okay, because they have given a clinical scenario, they have given a radiographic scenario. But if I would have been an examiner, I would have also told you about the pulp vitality status here. What is the vitality of the pulp? Whether the pulp in the central incisors is vital or not. Okay. Even that will help you in determining what the treatment plan should be. Okay. So I'm getting a couple of C's here. Okay. So either it is a vital bleaching or it is a root canal followed by veneers, or it can be root canal followed by non-vital bleaching, or D, it can be wait and watch, is what they are saying. So let's come to the answer. So it is endodontic treatment followed by non-vital bleaching. We have to go ahead with the endodontic treatment since the teeth are getting yellowish. Further, they are going to discolor more and the patient is going to have aesthetic complaints. That is why we go ahead with endodontic treatment followed by non-vital bleaching. Here we are going to go ahead with non-vital bleaching. Yes, because we have completed the root canal. Okay. After completion of the root canal, you condense your gattaparcha above the orifice level. Okay. You cut the excess of gattaparcha. You give a white cement like glass ionomer cement. Okay. You place it there above which, okay, you can place your bleaching agents, preferably used in non-vital bleaching, and then go ahead with a permanent dressing. Also, you can activate this bleaching over a span of 7 days, 14 days, and as and when required to check about the yellowish discoloration that is there in the patient. Okay. Treatment of uncomplicated crown fractures involving dentine to protect pulp is, so uncomplicated crown fracture we are talking about, that is involving dentine, but we are protecting pulp. So what is the treatment of such kind of uncomplicated fractures? So first is light cure glass ionomer cement. Second is light cure calcium hydroxide. Third is dentine bonding agent application. And fifth is chemically cured calcium hydroxide. Yes, I'm getting a responses from you guys. Yes, great. You might be wrong. That is not a problem, but answering it is very important. Okay. So it is light cured calcium hydroxide is the answer. Okay, because light cured calcium hydroxide will stay in the dentine and it will protect pulp from any further trauma. You can also go ahead with giving a composite layer above it. Okay. Recommended splinting time. Again, a very, very important question about splinting. This is very commonly asked in your AIMS questions, that is INI-CET or NEET questions as well, because there are various days for various, the splinting time for various kind of treatments. You can see, okay, in various types of injuries. Basically, in traumatic injuries, we have various splinting times. So recommended splinting time for extrusive luxation is either 2 weeks, 8 weeks, 4 weeks, or 12 weeks. So splinting time for various kind of traumatic injuries are definitely being asked in every year. If you just see the question papers, almost in every year or every alternative year, you'll see the splinting time that is being asked for traumatic injuries. So very, very important to go ahead and read about splinting times. Okay. Traumatic injury is also a very favorite question of theirs. We'll just come to the further slides. We'll get to know that the traumatic injuries are being asked very commonly. Okay. So recommended splinting time after extrusive luxation, you have 2 weeks, 8 weeks, 4 weeks, or 12 weeks. So the answer is 2 weeks. Okay. There is this table given by Anderson and Anderson wherein you have type of trauma. Okay, what are the types of traumas and what is the duration of immobilization along with the type of splint that you have. Okay, so the type of trauma being subluxation, you have duration of immobilization being 2 weeks. If it is extrusive luxation, that is the teeth are coming out and you need to stabilize them again back, you have 2 weeks time with a flexible splint again. There is avulsion that the entire tooth has come out. Okay, again, if you placing back the tooth, you have again the immobilization time being 2 weeks with a flexible splint. Whereas coming to lateral luxation, wherein the tooth is displaced laterally, or fracture of central third of the root, okay, or the fracture of cervical third of the root, all these things come under 4 week splinting. Okay, the splint can vary from flexible to rigid depending on the condition. Okay, fracture of the alveolar process, yes, definitely it is going to take much more of time to heal, so almost 4 months time is required with a rigid splint. Okay. So this is very, very important chart because they can ask you from any of this. They can ask you about subluxation. They can ask you about extrusive luxation. So here the question being extrusive luxation, it is the answer being 2 weeks. Okay. Coming to the next image-based question, a 8-year-old girl met with an accident and fractured her maxillary left central incisor. The treatment shown in this picture is, first is MTA apexification, second is calcium hydroxide apexification, third is periapical surgery, and D is regenerative endodontics. I'll just wait and let you guys see the picture properly. Okay. First read the question, go back to the picture, see what all things you can find there. I can find an open apex here. I can see some kind of treatment being done here. Then I can see something that is being done here. Okay, so this is a progressive picture of some kind of a treatment that is being done. If you follow it properly, you'll get to know what kind of treatment is being done. Okay. Yes. So if we negate here, it is definitely not a periapical surgery. It is not a periapical surgery. Okay. In periapical surgeries, we generally cut this root. Okay. So basically, 8-year-old girl. That means her root formation is not complete, right? So once the tooth erupts in the mouth, it is from 6 to 7 years. Then it takes almost around 1.5 to 2 years to the root to seal completely at the apex. Okay. So we are talking about something like an open apex here. So even if you don't have an X-ray, you should imagine that 8-year-old girl will not have a completed root, or it is in the process of completion. Okay. So she's going to have an open apex for sure. She's met with an accident and fractured her maxillary left incisor. Okay. The treatment shown in the picture is now, if you just see, they have made an access cavity preparation. Okay. And also they have placed a medicament here. Okay. That can be any kind of medicament. No endodontist will get to know what kind of medicament is there only by seeing an X-ray. Okay. You can never predict that which kind of medicament is there without knowing it. Okay. With just seeing the X-ray, because everything will look radio opaque in terms of different types of opacities. For example, here, if you see at the apex, you have a different kind of opacity, whereas the rest of the chamber, you can see a different kind of opacity. Okay. So this is basically a sectional obturation that is being done. You can say that this can be MTA, and the rest of the thing is being filled by your obturating material. Okay. So basically, they have done a MTA apexification. There are two types of steps for treating an open apex. One is apexification, the second is apexogenesis. Okay. So here C and D are entirely negated because this is not a regenerative endodontics at all. In regenerative endodontics, you place some material inside some agents like PRF. If you are aware of PRF, that is a platelet-rich fibrin that is being basically in this step in regenerative endodontics, you take the blood from the patient. It is being centrifuged. Okay, your red blood cells and other materials settle down, whereas you get a fibrin clot that is being placed inside this particular canal, and we wait for this tooth to regenerate at the apex. Okay, so it has growth factors which will regenerate the tooth. Okay, so this is called as regenerative endodontics. Definitely, it is not the regenerative endodontics since everything is being seen. Okay, so it is definitely an MTA apexification wherein, as discussed in the previous question, you have a MTA barrier of 3 to 5 mm, okay, above which the obturation is being conducted, right? A 12-year-old male patient reported with severe intrusive injury. Now the tooth has gone inside, intrusive injury to 1-1. When should endodontic treatment be planned in such scenarios? So either it is going to be immediately after orthodontic repositioning, after 4 weeks, endodontic treatment is not required, is what they're saying. And D is after 2 months once it stabilizes. So we'll just wait for your responses. Let's see. First is immediately after orthodontic repositioning. Second is after 4 weeks. Third is endodontic treatment is not required. And fourth is after 2 months once it stabilizes. Such kind of questions you'll have to imagine because they are not given any kind of X-rays. So it is a 12-year-old patient who reported with severe intrusive movement. So something has been hit him and the tooth have gone inside. That is called as intrusive injury. If the tooth are coming out, that is called as extrusive injury. Okay, if they are placed on a side lateral or say left or right, it is called as lateral excision. When should endodontic treatment be planned in such scenarios? Okay, I've got a couple of answers. We'll just move to the answer. Immediately after orthodontic repositioning, we have to reposition such kind of intrusive injuries. We have to settle back the teeth at their own position. Okay, you just have to retract them back to their normal position. Immediately splint them. Okay, by orthodontic repositioning. Okay, and go ahead with your root canal treatment. Okay, or endodontic treatment. Root canal treated teeth chances of extraction are reduced multifold if cuspal coverage is given 4 months after root canal completed, 6 months after root canal is completed, 9 months after root canal is completed, and 12 months after root canal is completed. So what they're saying is you have completed the root canal, the chances of extraction are reduced multifold if the cuspal coverage is given. Okay, 4 months after the root canal, 6 months after, 9 months after, or 12 months after. Okay, so it's an easy question. They have just complicated it a bit. Okay, we have a root canal treated tooth. When are the chances reduced? Okay, multifold if the cuspal coverage is given. So it is going to be after 4 months. The less number of duration is there, you mark it as the answer, because the less number of time goes after the root canal to the crown placement, the better it is for the tooth, because after your root canal, the tooth generally loses its moisture and also loses its strength by 25 to 30%. Okay. If there is one single marginal ridge that is being lost, almost 30% of the strength of the tooth is reduced. Okay. So any kind of root canal treated tooth loses moisture, it loses fast. And that is why there is chances of vertical fracture if you're not treating the tooth and giving it a good coronal restoration. Once the root canal is done, that is why after the patient settles down, he is asymptomatic, you go ahead with a permanent restoration. Okay, that is composite restoration, over which you prepare coronally the tooth properly and give a crown to the tooth. Okay. Now, again, a very important and a very interesting question. Which generation nickel titanium instrument is shown in this picture? Very interesting question. This is nothing but a cross section of a file. Okay, these are the nickel titanium files that they are showing. They have various cross sections. Okay, a typical cross section is shown. If you ask me, this is a offset. Okay, this is not in the center. You can see the this particular area. It is an offset. Okay, rectangular area, rectangular cross section with an offset design. Okay, the center is not. You can see this particular area not being in the center. Okay, this is an offset file. Okay, this is a quite a big hint for your answer. We'll just wait for a few responses and then go back to the answers. So either it is third generation, fourth generation, fifth generation, or sixth generation. They are asking us, seeing the cross section, which kind of nickel titanium instrument it can be. For your information, guys, we are into INI-CET MDS May 2023. Okay. So on the right hand side top corner, you will get to know where the question has been currently asked. Okay. So which generation nickel titanium instrument is shown in this picture? Either it is a third generation, fourth generation, fifth, or a sixth generation. So it is a fifth generation. As I told you, it is a rectangular cross section with being an offset file. It is a fifth generation nickel titanium instrument. Please be very thorough with all kind of cross sections of instrument, because they can ask you any kind of instrument. They can ask you third generation instrument. They can ask you a sixth generation. They can just show you a cross section of a nickel titanium instrument and ask you about which generation it is. Also about the metallurgy, because the metallurgy is nowadays into very much of action. M-wire technique. Okay. Electroplating of the files. You should be very, very aware of all these concepts. Okay. You should be also aware of the alloy techniques. Austenite, martensitic, all these kinds of alloy techniques that are there, alloy types. Okay, you should be also aware of those. How the shift of alloy takes place from one phase to another. Okay, what is a M-wire technology? All these things can be asked in your multiple choice question, because these are the newer things that are there in the market. So just to give you an overview, okay, the first generation files are U-shaped files. Okay, the second generation files, they are actively cutting without radial lands. Okay, I've given a couple of examples like M2 or edge race. Okay, so these are the second generation instruments. Third generation instruments are R phase, M wire, CM wire, blue and gold surface conditioning. Okay, these were the third generations. Okay, fourth generation are based on kinematics, reciprocating motion, single file system, single use concept. Okay. We also had a file called as SAF. Okay, so this was a hollow file. Okay, wherein it had this is also called a self-adjusting file. So this was a mesh work. Okay, so these are called as fourth generation files. These are just a mesh along with irrigation. So while you're preparing, you're also irrigating the canal. That was the concept of this file, but these are nowadays not used. These were the fourth generation files. Then you have fifth generation files. As I told you, they are offset from the center of rotation. If you see the previous image, if going back to the previous image, yes. So this is the center of rotation. It is offset from the center. It is not exactly at the center. So any offset file is definitely a fifth generation file. You can see here offset file. It is away from the center of rotation. It reduces taper lock. Okay, it reduces the taper lock and non-contact space for better debris extrusion. If it is contacting at all four spaces, all 4 points at a time, the debris removal will be ineffective. So the example being one shape, Revo S. Okay. Coming to sixth generation, these are incorporation of engine-driven instruments for glide path, innovation in irrigation, that is like SAF, XP finisher for retreatments. And the seventh generation are based on new manufacturing techniques. These can be twisted files, shape setting files, true shape or XP shapers, okay, or EDM, that is electric discharge machining. So these are the fewer newer files of seventh generation. Please be aware of all these concepts because they can ask you anything from this concept. Okay, they can ask you where is the MWire technology that is being used. So it was used in the third generation. So likewise, you can get any kind of question. So what we have got here is the fifth generation. All right. So we have got many answers right in this particular question. Coming to the salivary vaccine is based on which antibody? Now, this is a very straightforward question wherein you can easily get to know the answer if you are aware of the concepts. Okay. So the first option being IgG, second being IgA, third being IgM, and fourth being IgD. If you know what salivary immunoglobulin is, you will get the answer right. It's IgA. Okay, because in your saliva there is IgA that is there. Okay, so the answer is IgA. Okay, so if you can see here IgA, it forms dimer after secretion and it is expressed in mucosal tissues. Okay, so basically it is there in your saliva. Use of 18 to 30 fluted carbide burr, whether it is used for polishing, grinding, contouring, or finishing. 18 to 30 fluted carbide burr, whether it is used in polishing, grinding, contouring, or finishing. I'm so sorry, I have to take these water breaks because there is very high temperature in Pune right now. We're facing almost a heat wave here. So use of 18 to 30 fluted carbide burr. It is used for either finishing, polishing, contouring, or grinding. A being polishing, B being grinding, C being contouring, and D being finishing. We'll come back to the answer. Yes, we have got a couple of D's, couple of E's and B's. So the right answer is finishing, okay, because 18 to 30 fluted burr is not going to cut much. So it is basically used in the finishing processes, okay. What is the difference between finishing and polishing is definitely a very, very important criteria for you to understand. Finishing removes the surface defects and scratches, created during initial shaping, resulting in a smooth surface. Whereas polishing is a final step, which further reduces roughness and provides a glossy structure that is required. Okay, or the final finish that is required, it is given by polishing. Very, very interesting question. Again, with the image-based question, we are here. Type of traumatic injury shown in image for the tooth to one. Okay, so this is the tooth to one. We can see which kind of injury here. As I told you, traumatic injuries is a very, very interesting topic for the examiners. They definitely ask you questions regarding these traumatic injuries. They can ask you treatments of avulsion teeth, treatment of any kind of other injuries. Okay, or they can show you such kind of pictures and they can ask you what kind of injury it is. Okay, so type of traumatic injury shown in image for tooth to one. A option concussion, B option subluxation, Option C being intrusive luxation, and D being lateral luxation. Yes, many of you have guessed it right. It is lateral luxation. Okay. In the picture, you can see they have displaced laterally as well. Okay. Coming to this question again, it is a very, very interesting question, and you should be very aware when you're answering such kind of questions in the paper. They have given you images of clinical and as well as radiographic images. Type of fracture according to Ellis classification. Either it is a class 1, a class 3 fracture, option B being a class 6 fracture, option C being class 8 fracture, and option D being class 9 fracture. You should be aware of all classes of fractures, okay, in this. Basically, people confuse between option A because you can see enamel, dentine, and pulp, all three involved here, okay, but this is the answer A is not right here. Why? Because in this X-ray, you can see some erupting teeth. So this is basically a pedo case. Okay. In pedodontic, any kind of fracture will be categorized under class 9. Okay. So class 9 is the answer. Yes, many of you, almost all of you have guessed it right. Yes, very good. Type of the following type of the following is shown in the image. What is this image basically depict? First is EPT, that is electronic pulp testing. B is caries detection using Diagnodent. C is curing of composite restorations. And D is scaling. There is a device that is there with a light on it. Okay. You can see a yellow light that is here. And then you have something, some electrode that is being placed there. Okay. You can see this isolation also of this tooth done. Okay. So definitely it is not caries detection using Diagnodent. It is not such kind of a machine. Curing of composite restoration, it would have seen a blue light here, right? Scaling is not done in this manner. So definitely it is going to be an electronic pulp testing. Yes, many of you have guessed it right. Yes, all of you have guessed it right. Very good. Okay, another interesting X-ray. A lady complains of sensitivity in the posterior teeth on eating ice cream, which is relieved immediately after finishing ice cream. Radiograph of the patient is shown in the picture. What will be the treatment for the patient? Either it is option A, sensitivity toothpaste, option B as root canal treatment with 4-6, option C, indirect pulp capping with 4-6, option D, direct pulp capping with 4-6. Yes, many of you have guessed it right. But if I would have been an examiner, I would have phrased this in a different kind of manner. A option being desensitizing toothpaste because there is no sensitivity toothpaste available in the market. It has to be desensitizing toothpaste. A lady complains of sensitivity. So basically, we have to have a desensitizing paste. Okay. Is the first thing that comes to our mind. But if you read the entire question, we have to go ahead with the reading the entire question because we are supposed to see what is there in the radiograph as well. Okay. So the she has sensitivity in posterior teeth on eating ice cream, which is relieved immediately. So this can be a case of reversible pulpitis. Okay. Radiograph of the patient is shown in the picture. We can see the picture. The radiograph is showing no periapical pathology, neither there is any coronal pathology as well. What will be the treatment for the patient? So it is going to be desensitizing toothpaste because there is no pathology which is either involving enamel, dentine, or pulp, or neither the periapical areas. Okay. A 10-year-old child presents with abscess with 1-2. On vitality testing, 1112 shows test as negative. The treatment should be or is revascularization of 1-2, RCT of 1-1, apexification of 1-2, RCT with 1-1, apicectomy of 1-2, RCT with 1-1, direct pulp capping with 1-1 and 1-2. Now here, for you to get given hint, if there is an abscess, your D option is nowhere stands. Okay, because you can't go ahead with the direct pulp capping thing. where when there is an abscess. Okay, since the vitality test is also negative, there is no use doing a direct pulp capping. Okay, so it is going to be revascularization of 1-2 and RCT of 1-1. Okay, since 1-1 is non-vital. Okay, whether and 1-2 has an abscess. Okay, is a 10-year-old child. That is why we are going ahead with revascularization of 1-2 and RCT of 1-1. Coming to an interesting case, these are not the actual pictures, but somewhat what the examiner wants from you guys. Okay, patient presents with owl's tooth. Okay, there is a missing tooth here. You can see there's a owl's tooth. The extraoral time is given 45 minutes after trauma. Okay, which of the solutions should be in the kidney trays? Okay, you have a kidney tray here. Okay, which of the solutions should be in the kidney tray is what they're asking. Should be option A, coconut water. Should be B, normal saline, whether it should be C, Hank's balanced salt solution, whether it should be D, minocycline. Yes, you have an hour's tooth here. Okay. Definitely, they can also ask you what is the grading of these things. Okay. Whether you're supposed to place it inside the normal saline or coconut water or Hank's balanced salt solution. HBSS definitely is the answer. You can use HBSS, but if HBSS is not available, what other things are best apart from these? So, if you don't have Hank's balanced salt solution, if the patient is old enough, you can place it inside the buccal vestibule of the patient, avoiding any kind of swallowing if the patient is in his senses. If he's unconscious, don't attempt such kind of things. You can use coconut water also. The coconut water has shown substantial, preserving of the fibroblast cells around. Okay. They have also said that milk can be a medium to preserve tooth as well. Okay. Don't use water. Okay. Normal saline can be the last option that is there. Okay. So grading wise also it is important. Coming to the answer, HBSS. Okay. Treatment of cervical root fractures seen in the image. Option A, root canal treatment. Option B is splinting. Option C is post retained crown. And option D is resin cemented bridge. Yes, I am getting a question here. Milk question mark. Yes, milk can also be used as a medium to preserve if nothing is there around. Okay. There are studies that have checked milk, coconut water. They also checked distilled water, but which is not effective at all. Okay, so there are various options that are there to preserve the tooth. HBSS being the best of it. Okay, treatment of cervical root fractures seen in the image. Option A, root canal treatment. Option B, splint. Option C, post retained crown, and option D, resin cemented bridge. Resin cemented bridge, we won't be doing the resin cemented bridge for sure. Okay. We are supposed to splint this tooth, observe, wait and watch. We should check for symptoms. If they don't subside, the patient is having swelling or the patient is having any kind of pain, go ahead with the root canal treatment. But for sure, first treatment of line should be splinting. Since the fracture is in the middle half or the apical region, it is not somewhere near the cervical region. Okay, if it is in the cervical region, definitely it is going to get contaminated. We are supposed to go ahead with the root canal immediately. Okay, identify the particular image. Okay, it is a wing clamp with bow, it is a wing clamp without bow, it is a wingless clamp with bow, or it is a wingless clamp without bow. Very easy question basically. Yes, with the amount of answers that I'm getting, I guess you guys have identified it. Yes, you have identified it right. It is a winged clamp with bow. You can see this is a bow, okay, and you have these wings, okay, for the clamp. So just for your understanding, I have given here, see, these are the winged clamps. These are the wingless clamps. There is no wing here extra. So these wings are basically for prevention of the slippage of your rubber dam material, okay, or the latex material that you are using as a sheet here, okay. So these are basically wingless clamps. There are no wings here, whereas here you can see the winged clamp or extra retention of that particular rubber dam sheet. Best method of isolation during vital pulp therapy. Is it cotton rolls? Is it anti-silox? Is it rubber dam? Or is it saliva ejectors? Very easy answer again. This is what has saved us from corona, and we were able to treat patients because of this in COVID period. Okay, so it is definitely rubber dam. Composition of KRI paste: zinc oxide, thymol, lanolin, iodoform, camphor, parachlorophenol, methanol, iodoform, camphor, parachlorophenol, methanol, and zinc oxide. And D is none of the above. Yes, we have got many of the responses right. Okay, so it is option B, that is iodoform, camphor, parachlorophenol, and methanol. So these are the contents of KRI paste along with the concentrations. You need not remember them because they don't ask you generally the concentrations of any kind of endodontic materials. It was introduced by Volkov. You can remember that as a resorbable paste suitable for root canal filling material. Okay. So it is basically used more of in pediatric dentistry. Okay. A 12-year-old child presents with tetracycline staining on teeth present for long time. Treatment for yellowish stains present on the teeth. What are the various kinds of treatment that you will prefer for this particular patient? Option A is HCl microabrasion. Option B is yes. So option B is right. We have got many option Bs here in the chat. So at home bleach is what we'll prefer in such kind of cases. Okay. Coming to again an image based question, what will be the treatment of choice for these conditions in the image for A and B? So first is A should be lined with calcium hydroxide and B should be lined with glass ionomer cement. Second is A should be lined with glass ionomer cement and B should be lined by calcium hydroxide. C is both should be lined by calcium hydroxide. And D is A should be lined with JIC and B should be lined by polycarboxylate. So D is entirely negated. We don't want D as an option because we are never using polycarboxylate in such deep cases. Okay. So in A and B, just see what is the difference between the cavity preparation. You can see this cavity preparation is much more closer to the pulp as compared to A, and the B is much compared to A, right? So both should be lined by calcium hydroxide. As both are being seen very close to the pulp, the remaining amount of dentin thickness is less. So we should line both with calcium hydroxide. Remember, polycarboxylate cement is never used in such deep cases. Okay. Now, this is the best picture I could get out of it. They're saying that ICDA score is either 3, 4, 5, or 6. Depending on this image, I am not able to make out whether you are able to appreciate this image. This is the best image I could get. I'm sorry. Yeah, some of you are saying 5. Yes, 5 is the right answer. You guessed it right, depending on the quality of the image. So, best for enamel amalgam junction. What is the best for amalgam enamel junction? Option A, whether it is A and C. You can see A and C as both the images. Whether it is A only, whether it is C only, this is C only, and whether it is B only. We are all sure that it should be a butt joint. Okay. So it should be A only. It should be a butt joint for amalgam. Okay. Amalgam junction should always be a butt joint. Again, a tricky question from conservative. In class 2 amalgam preparation, sequence of steps should be: first is convenience form, second outline form, third is primary resistance form, fourth is primary retention form. Here's the most neglected part. We generally don't recollect the steps. So A is 1, 2, 3, 4, B is 4, 3, 2, 1, C is 2, 3, 4, 1, and D is 2, 3, 1, 4. The such kind of questions will definitely check the basics of yours. We are prepared for the worst ones, but these are the ones you generally neglect upon. So it is option C. You have outline form. Yeah, definitely outline form is the one that is visualized by the operator first by seeing the tooth. Okay, then you have primary resistance form. Then you have primary retention form, and then you have convenience form. Convenience form is nothing but the form that is used to to check whether the cavity is visible or whether the cavity is accessible properly by the clinician. Okay, so all these things, if you just see the sequence, it should be 2, 3, 4, and 1. Acid etching helps to: first is increase surface area, second is increase wettability, third is increase surface energy of enamel, and fourth is increase surface energy of dentin. So either it should be A, that is 2 and 3, B, that is 2, 3, 4, C, that is 3 and 4, D, that is 1, 2, and 3. Again, as I told you, you can neglect one that is odd. Okay, so you just remove either those are wrong or remove those are right, so that you can analyze this question easier. You would have a rough page around to just tick the ones which are correct and which are not correct. Okay. Yes, the right answer is D. That is 1, 2, and 3. That is increase surface area, increase wettability, and increase surface energy of enamel. All these three will help in conditioning of the enamel properly, okay, and will improve the hardening of enamel. So also, if you are talking about acid etching, okay, you should be also aware of all the concepts regarding dentin bonding. Okay, who's given which kind of total edge is given by whom, or what is the concept given by Nakabayashi? What is hybridization concept? All these things should be also known by you because they can ask you any of the concepts. What is total edge concept? Okay, what is the concept given by Fusuyama? These are all scientists who are Japanese. They have worked extensively on the bonding concept. This is again very well explained in the textbook of Conservative Dentistry and Endodontics, which we have given. There are very nice diagrams also there, okay, which we have explained it in good terms of mind maps as well. Okay. True about pit and fissure sealants. Now, again, you'll have to negate all the things that are not right for this. Sealant, if removed in first 3 months, creates faulty placement procedures. Sealant, if removed after 3 months, it is due to abnormal masticatory forces. Sealant used as treatment for incipient caries and arrested small caries. And fourth is retained for longer duration in maxilla and in mandible. So these are the options. This takes time to analyze. Okay, just don't rush into the answer because this is a bit of a time wherein you will have to sit, analyze all the options, come to the answer in some point of time. Okay, don't just rush into a single answer. Okay, just wait, analyze all the options. Okay, and then come back to your inference. Okay, so it is 1 and 4. Sealant, if removed in first 3 months, then it is faulty placements. And fourth is retained for longer duration in maxilla than in mandible. Okay, so that is the right answer. Indications of pit and fissure sealants. Again, sealants used for deep pit and fissures, sealants used for smooth surface enamel caries. Remineralization can be done in incipient caries and white spots, and enamel caries and proximal caries involving pit and fissures. So again, approach for this answer is you remove off or you negate all whatever is false and stick to the indications that are there. The option A, B, C, and D. Okay. This kind of questions, you spare some time if you are in a hurry to solve other questions and you have less of time for these ones, you can keep them for the last. Once you're done with the entire paper, come back to this question, can read it properly, take a rough page and try and analyze which of them are right and which of them are wrong. Okay. So first three are right. That is the indications. Sealants used for deep patent fissures. Okay. Then sealants used for smooth surface enamel caries. And also remineralization can be done in incipient caries and white spot. Now white spot lesions are generally they can be remineralized. We have various remineralization agents. Those can be ACP-CCP. That is the casein protein that is there inside the milk. That is nowadays available in the form of toothpaste. Okay, it is called as ACP CCP. Okay. Best method to increase life of pit and fissure sealants. Uh, Increase depth using small round burr. Give strength by composite bulk. Ensure cleaning and control excess moisture. And these acid etching 2 minutes before application. Okay. So what is the best method to increase the lifespan of a pit and fissure sealant? Getting a couple of answers. Yes, and the answer C is right. Ensure cleaning and control excess moisture. Yes, many of you have got it right. Definitely. So I guess you guys are prepared for INI-CET. Great. For an area to be considered carious, minimum reduction in fluorescence should be. Okay, so how much should be the minimum reduction of fluorescence if you're considering an area that is carious? Okay, either it should be option A 5%, option B 10%, option C 15%, option D 20%. Now the question here that they're trying to say is if you have a carious lesion, there is definitely a reduction in the fluorescence that can be achieved. So various devices are being, available in the market to check the reduced fluorescence of that particular carious tooth. Okay, so either it is 5%, 10%, 15%, or 20% is the question. So the answer is A, 5%. If there is also only a 5% reduction in the fluorescence of that particular tooth, that means the area is carious. Okay. In teeth affected with molar incisor hypomineralization, what is the reason for enamel adhesive bond failure? Okay, so you have a molar incisor hypomineralization. In hypomineralization, there is less of mineral content. Okay, and there can be bond failure. The enamel adhesive bond can fail. So, what is the exact reason? Option A being inefficient bonding system used because they have said hypomineralization, so improperly formed tooth structure. It can't be excess salivation because you have a molar is being mentioned. So